We
Hello?
can hear you.
Everybody?
Yep.
Okay, that's great. Okay, then I start with the place of RCT in health promotion evaluation. Okay, here we are. I will talk about the terms at the beginning, then about the context, where I hopefully make clear why this topic is important, the questions which should be answered, hopefully, and the conclusions I draw out of all what I talked before. Let's start with health promotion. Here you see two pictures which for me make very good clear what's the difference between health promotion interventions and classical clinical interventions. When I go to literature, you see Untitled Chapter, Jakarta Declaration. There are two declarations, Charter from WHO, which makes pretty clear what health promotion is. It's the process of enabling people to increase control over and to improve their health. But I think much more, it's clearer in the Jakarta Declaration, where WHO says health promotion is carried out by and with people and not on or to people. How can we understand this? Bring me an example. If you look at the setting of schools, and there is a project, cluster RCT, we conducted in the last 2 years. It's an intervention in school classes where teachers get trained in a kind of teaching style which is more adjusted at the needs of the students. It's about a didactic style which enables students for physical activity during the lessons. There are several examples. For example, there's the possibility for students to make a diktat where they have to go to several places in the classroom where they find part of sentences, and the goal is that they put the sentences together, that they fill up missing words, for example. Okay, but this makes clear that the intervention is hardly be separated from the context in which it takes place, and that the intervention itself are people, that the intervention is carried out by people and with people, and not only on or to people. The third definition, I don't go in detail here, is about evidence-based health promotion, just to make it clear, and to the question I ask about the role of RCT in health promotion evaluation is about how we can get evidence-based information about the question if programs works in health promotion. The second term is, and I think everybody thinks about it, or already thought about it, it's about complex intervention versus simple interventions. I think it's obvious that health promotion interventions are complex interventions. And from the Medical Research Center Guidance on Complex Interventions, I brought here 3 characteristics of complex interventions. They are non-pharmacological, they are behavioral, and they have weak links in the causal chain between the intervention and the health outcome. And I put another characteristic from Armstrong: they have longer causal chains between intervention and outcome. To make this clear, I bring here the Swiss model of outcome classification in health promotion and prevention, where you see at the right side the health status of the population. When I do you see the pointer? When I move the pointer at the presentation, when I go to health status of the health of the population, could you see this? Hello, Megan, you're here?
Yes, sorry, we're on mute. We can see it. Thank you.
Okay. health status of the population, it's here you see the indicators. It's like healthy life expectancy, quality of life in terms of health. And the most health promotion, but also prevention interventions, it's not easy to measure this, and it's not easy to get a causal chain between these outcomes and the intervention itself. Therefore, there is the Swiss model for outcome classification in health promotion and prevention, where at the left side here you have the kind of intervention. There could be infrastructure and services, legal systems, for example, fat tax, group communities and populations, and on the level of individuals. Here you have the measures, the kind of intervention. It's not the time to go in detail, but it's just to show you that there are health determinants, for example, which are linked to the measures and to the health status of the population. Here it's a second example where it's on a practical example. For example, health promoting services here at B1, or health promoting public policy and organizational practices, social and potential commitment, health related life skills. And you see there are goals under these headlines, and they are linked to the determinants of health, like health promoting physical environment or health promoting social environment. You see, it's a characteristic of health promotion interventions that they have causal changes, but you can, and that's important, there's a system for classification of these parts of this causal chain. Then there is a discussion about complex interventions versus simple interventions. The features of complex interventions are the number of interacting components. It's also from the Medical Research Center. The number of difficulty of behaviors required to those delivering or receiving this intervention. For example, in the setting of schools, where we made this RCT, this cluster RCT, there are the behaviors of the teachers which are important for this intervention. There are the behaviors of the trainees for these teachers and the behaviors of the children. The number of groups, organizational levels targeted by the intervention. For example, there is on this setting in schools, there is the level of individuals. Then there is on the student, on the pupil level. And then we have the teacher, and we have the whole class on the class level. There could also be the level of schools, which is another level which could be observed. The number and variability of outcomes, we will come to this point later, that we have not only one primary outcome, but we have more than one primary outcomes. And the degree of flexibility, which is tailoring, or flexibility or tailoring, which is permitted or are permitted. I will come to this point also later about the question of standardization of complex interventions. And here we are at this discussion. There is also a discussion about complex interventions versus simple interventions. When I talked with Gerald, for example, he said also biomedical interventions are complex interventions. And I'm sure they are. And there I have two sentences, one from Gilles, which said, we need to recognize whether we have a complex intervention or an intervention in a complex system. I think this is an important part. Even the human body is a complex system, I'm sure. But social systems, we can discuss about it, even more complex than biomedical systems. If we look for this example, school, and the question of, okay, a school with teacher, with students, with trainees, on the countryside or in the city, this is a complex system, and we have here an intervention in this complex system. Pettigrew has another point of view. He says that it's a matter of perspective. He says there are few, if any, true simple intervention, and he says not every complex intervention requires a complex analysis, unless the research question demands it. And I think this is a third factor which is important to recognize if we discuss about complex interventions versus simple interventions. It's the question of the research question. But if you have the research question with a complex intervention in a complex system, like public health intervention to improve physical activity of students, which is implemented in a setting of school, in classrooms, and we want to know, does it work? This is not an easy or simple question. Okay, and then last but not least, what's about the randomized control trial? RCTs are the most rigorous way to evaluate effectiveness of interventions. I'm sure everybody agrees. And to make it clear, what are the key features of randomized controlled trials, RCTs? It's the randomization procedure and standardization procedure and the protocol, which are used to reduce selection bias. And in an ideal world of RCT, the differences between experimental and control groups may be attributable to the intervention and only to the intervention. And there's the need of non-biased selection of participants into experimental and control groups to get valid answers and evidence-based information about what works. And therefore, the study designs were graded by the potential to eliminate bias. I brought here the example that RCTs were favored over other study designs. For example, the US Secretary of Education put on RCTs in 2003 the highest priority on the question of which study should be funded. But there is a discussion in public health if randomized controlled trials are appropriate or are they inappropriate. And the discussion here, I sum it up, the key sentences why RCTs should be inappropriate. The first sentence, which you can find at NAPIM or also at WHO, European Working Group on Health Promotion Evaluation, was that the question of standardized or the interventions had to look the same in RCTs, the standardization of the intervention. Then there's the question about that it should be unable to accommodate the complexity and flexibility that public health programs are characterized. This means that public health and even health promotion intervention are tailored to the needs of the target group. And if there are different target groups, which should, for example, in the setting of school, it's easy because there's only one target group. There are children in the third and in the fourth grade, but there are other public health interventions where it is not as easy. For example, if it's about programs to prevention program for preventing obesity, for example. It could be more than one target group. And then the third point, we have different settings in health promotion. The question is how to recognize this in cluster randomized trials or in randomized trials. And therefore, some authors came to the conclusion that RCTs are only feasible for evaluating relatively simple and standardized and unvarying intervention. And yeah, last but not least, the question of context level adaptation. This means that the intervention is adapted to the context in which it takes place, for example in schools, for example in this one setting, another example of a setting would be workplace, for example. And intervention should be adapted to the school or to the workplace. And how to evaluate this with randomized controlled trials. Therefore, we are at the main question, can a controlled trial design, which requires something to be replicable and recognizable as the intervention in each site, ever be appropriate to evaluate a truly complex intervention? And I will make it clear on these 3 points, on the question of standardization, on the question of randomization, and also on the question of how to interpret the results. What are the challenges of standardization in workplace, also in health promotion? As I told before, many public health interventions require multiple and flexible and community-driven strategies. This means that they are adapted to the target group and also to the context in which they take place. And there is a recognition that this is necessary, that these interventions are adapted to the local context. And even Craig et al. In the Medical Research Center said that the strict standardization may be inappropriate for the evaluation of complex intervention. And there should be a specified degree of adaptation to local settings. So this should be allowed in the protocol. Okay, but how to do this? The question is, what should be standardized? And there's one way to distinguish between form, the components of the intervention, and function, the steps in the change process that the elements are purporting to facilitate, or the key function that they are meant to have. The form, which is usually the thing we are thinking about when we talk about standardization, it's about, okay, the information kit, being, for example, at the setting in schools, this intervention for more physical activity of these children. We can standardize this intervention by workshops, for example. And these workshops should be in every school the same. But we can also ask, okay, what are the key elements to facilitate more physical activity in classrooms? To make it more clearer, bring an example out of the literature where they have example of alternative ways to standardize a whole community intervention to prevent depression in a cluster trial. And here you see the principle of the intervention on the left side, and I just go on the first row. Here we have to educate patients about depression. When I standardize it by form, it should be all sites distribute the same written patient information kit. When I go by function, all sites devise ways to distribute information tailored to local literacy language, culture, and learning styles. In this example, we have further example how to separate between form and function. What it makes clear here is that function gets more degree of flexibility in designing the intervention. I don't think it makes sense to go to all 1, 2, 3, 4 examples. I think you can download the slides and the procedure, the logic behind is the same between form and function. And to sum it up, in complex intervention, the function of the process of the intervention should be standardized, not the components themselves. And the intervention integrity would be defined as evidence of fit with the theory or principle of the hypothesis change process. But this means that there should be a theory of intervention underlining the intervention, which is necessary that that there is a fit between theory and principles. And the common definition of standardization treats a complex intervention like a simple one. And there are even authors which says that the standardization of health promotion intervention, for example, could be the reason that the outcomes are often poor, because the necessary adaptation on the target group and the local context couldn't take place in the way it should be. Okay, then I hope there aren't so many questions about standardization, but I go further on to randomization. I think it's better to discuss all these open questions at the end of the presentation. Randomization. It's also a key element of RCTs, and it should always be considered because it is the most robust method of preventing selection bias. Okay. Okay, everybody hears me now? There was a mute. Hello?
Yes, it should be working now.
Should be working now. Am I too quick, or is it okay to follow?
I think it's a good pace. Thank you.
Okay. Okay, let's go to randomization. Also, here's the question: what should be randomized? There are special characteristics of health promotion and public health intervention. Mostly they are delivered to groups, areas, institutions, or systems collectively rather than individually. For example, these schools, the intervention is delivered to the teacher, yes, and to the whole class. Testing the delivery on an intervention to an individual might raise concern if others are not included. This means selecting several students out of the school or the class which are in the happy situation to be a part of this intervention opens the question, why are the others excluded? And there are also potentially conflicting interaction between these taking place and these not taking place on the intervention. There are carryover effects. This means it's possible that if you separate, for example, children from the class which take place in the self-promotion intervention from these not being part of the health promotion intervention. There are carryover effects. They talk with each other. Interested in the mass effectiveness of intervention that will be rolled out to the public even if they have been shown to be efficacious in individual cases. That's the question if does it also work in groups or bigger groups comparing to individuals. This means especially for health promotion cluster trails are important. And the defining feature of a cluster RCT is that the unit of allocation is a group rather than an individual. And this is a cluster RCT not because of methodological considerations, a cluster RCT because of practical implementation considerations. Okay. Then we have a few challenges even in randomization. Blinding, so that we have these special conditions, blinding and masking are not possible in health promotion. If, for example, got this intervention in schools, it's not possible that the teacher or the children doesn't know if they're in intervention or control group. There is no placebo. This is obvious, I think. And the second is informed consent, even ethical consideration. This means only informed participants who are willing to be randomly assigned. This is not necessarily a special condition on health promotion intervention or public health interventions, but I think it's important to mention here because there are consequences out of these both special conditions. And these consequences are post-randomization selection bias effects the internal validity of the cluster RCT. There's one point which is the subject preferences before randomization. Because if you think about a group which says, okay, yes, we agree, we will be part of this cluster RCT, but I really want to be in the intervention group. And after the randomization process comes out, okay, I'm not in the intervention group. Okay, maybe I'm frustrated and the probability for dropout is much higher. We are now in the situation that we make the analysis of this cluster RCT in this school setting, and it seems that the dropouts in the intervention groups is much higher than, sorry, the other way around, that the dropouts in the control group is much higher than in the intervention group. And this leads to unbalanced dropouts, which has an influence on these two groups, which are not as equal as they should be. The second is the question of resentful demoralization or compensatory rivalry. I put it together because both is the same principle behind. That the control group, for example, children which are part of the control group, or even teachers which are part of the control group, that one part could be demoralized because they wanted to be in the intervention group, or they can show increased performance to show, okay, we are as good as the intervention group. And this has also an effect on the results. And we have the experimenter effects because the expectancies of the experimenter. Therefore, it's important that the ones who are testing, for example, in the schools, don't know which is the intervention group or the control group. But this is possible in health promotion evaluation. And it should make clear that the one who is responsible for the program or this is responsible for the intervention isn't part of the evaluation team or has no important role to influence the evaluation. Okay, to sum up randomization, the first thing I think is clear. This means that cluster randomizations are more appropriate for public health than individual randomization. And that there are post-randomization selection biases which should be considered. Last not least, the third point, the question of interpreting results. There is one part that the sample size is often smaller than expected. We had about 26 classes in the intervention group and 26 classes in the control group. And we had good luck that even at the follow-up, all these 26 classes were still in the study. But if there is a dropout of clusters, the probability that the cluster shrinks to a sample size that is where the expected characteristics about the equality of this intervention and control group no longer exist because of the small sample size. The second point is about negative findings. What is if the results are negative? There is no intervention effect which could be shown by the evaluation. There are two possibilities why it is. So it could be it was a failure of the evaluation to demonstrate this underlying effectiveness, or the program itself didn't work. Evaluation failure versus program failure. The evaluation failure is the question, okay, where are the outcomes relative to the program goals? Did the outcomes fit to the intervention theory? Here we are again at the intervention theory and the goals of the intervention, which are necessary for answering this question about are the outcomes according to the program. Program failure, second point. Is it a failure of the intervention? Did the intervention work, or didn't the intervention work because the intervention itself is nonsense, or why it could be that it was poor, there was a poor implementation of a good, solid intervention. Therefore, we have two questions which are necessary to answer in a cluster RCT or RCT at the end. The question one is, was there a solid intervention theory? Is there a theory behind this intervention? I'm sure in biomedical clinical intervention, like pharmacological studies, there are clear intervention theories. In public health, or especially in health promotion, it's often hard work for the evaluator to get a solid evidence-based intervention theory. To the second question, was it a poor implementation? This brings us to another part. It brings us to the answer that there is necessary to have a process evaluation simultaneously with the RCT or cluster RCT. And this process evaluation should be measured how was the quality of the implementation. But only when I have this information at the end, I can answer the question how the intervention was implemented. And maybe it was poor implemented in several classrooms or schools. And we have the external validity, the question about to whom does it apply. Here I have a sentence from Cochrane. He said, between measurements based on RCTs and benefit, in the community there is a growth which has been much underestimated. The question is about external validity. Here I wrote four, from my point of view, important questions to answer this. the first is what was the setting of the trial, for example, schools. We have an intervention evaluated for more physical activities for children in classrooms. Okay, the setting is clear. How was the selection of the patients, here patients or the participants? The characteristics of randomized participants and the differences between the trial protocol and the routine practice. Is it in an experimental setting or is it in a real-world setting? Unfortunately, about the guidelines of the evaluation of complex intervention, there is very little information about how to make sure that the external validity is high. To sum it up about the study results, the requirements for correct interpreting. This first is, once again, a sound intervention theory that explains the causal changes. The model I brought before, the Swiss model of outcome classification, could be a good, good guideline for this intervention theory. It's important that outcome measures represent program goals. I think this is obvious. And even in complex interventions, there should be more than one primary outcomes. Even the Medical Research Center in his guideline about evaluation of complex intervention made this clear. And it is necessary to have a process evaluation ongoing beside the cluster RCT to know how the intervention was implemented. And here I come to my conclusions. The first conclusion is that the study design alone is an inadequate marker of evidence quality. I think I made it clear that there was other important aspects for example, that we need a process evaluation, that we need a valid intervention theory. I'm sure, and there is a place, especially for cluster RCTs in health promotion evaluation, and maybe best to use to test the causal hypothesis after pre-post single group design has been conducted. It's a lot of work and it costs a lot of money to conduct a cluster RCT, and therefore it should be not the first step in evaluating a program. It's a good idea to have a few studies before to make sure that the outcomes are really that the outcomes fit the intervention, for example, and even to have information about how on which bandwidth the change of outcomes could be expected. And the third conclusion is if a cluster RCT is conducted, it should take into consideration that they are more complex to design, they require more participants, and they require more complex analysis. And there should be an intervention theory, that the standardization should be by function and not by form, that the randomization is by clusters, and that there should be an embedded process evaluation. And even if all the things as a cluster RCT is done, recognizing all these ideas, still there are threats for internal and external validity. And this should be reconsidered. This means that cluster RCT or RCT in health promotion doesn't mean it's automatically a high internal validity. Okay, thank you for your attention. I hope it was clear, my thoughts, and I'm open to